Today, we are cracking the case of nursing assessment, because in the clinical world, you're not just a nurse, you're a detective. And honestly, your ability to solve the mystery in front of you can be a matter of life and death.
Okay, let's just get right into it. When it comes to the next generation NCLEX, assessment isn't about just checking boxes on a form anymore. The entire game has changed. It's all about recognizing cues. Your job is to walk into a room, scan the entire scene, and spot that one subtle clue that screams danger. You're the first line of defense. You're the clinical detective on the case.
And you know, every single investigation, no matter how complicated it seems, really just boils down to these two fundamental steps. It's that simple. First, you collect the evidence. That means gathering all the clues, all the facts you can find. Then, step two, you interpret that evidence. You have to figure out, what does it all mean?
So, here's our game plan for today's investigation. First, we'll really nail down our role as the detective. Then, we'll get into the two main types of evidence you'll find. After that, we'll cover the patient interview, a killer tool for analyzing symptoms, and the crucial difference between facts and conclusions. And we'll wrap it all up with a briefing to get you totally exam ready. Let's do this. So, let's start here with your role as a detective. What's your primary mission? It's simple. Recognize cues. I want you to think of your brain as this high-powered scanner. It's constantly sifting through hundreds of little data points, sights, sounds, numbers, even smells, all to find that one critical clue that's going to crack the whole case wide open.
All right, so you know your mission, but every detective needs to understand the evidence they're working with. And in any clinical investigation, you're going to be dealing with two fundamental types of evidence as you start piecing together the facts of the case.
Okay, this analogy right here is everything. I want you to think of subjective data as witness testimony. It's what the patient tells you. It's their feelings, their story, their symptoms. You can't see it or measure it yourself. Now, objective data, that's the forensic facts. This is the hard evidence you observe and measure, like vital signs, the size of a wound, a patient's grimace. One is the story, the other is the science.
And this is a perfect example of why subjective data is so powerful. That's not just chest pain, is it? No way. That specific quote paints a vivid picture of the quality of that pain. And here's the crucial part. You have to document these statements in the patient's own words. It's their direct testimony, and it is absolutely priceless.
So where does all this evidence come from? Well, your primary source, your number one go-to, is always the patient. They are the absolute best source of information about their own body. But what happens when a patient is confused or unconscious, or maybe they're a child? That's when your secondary sources, family, medical records, other providers, become absolutely essential to piece together the full story.
Okay, so you've got your sources lined up. Now, how do you actually collect the evidence? This brings us to the patient interview. And I really want you to stop thinking of this as just a friendly chat. Think of it as a structured interrogation. It's truly an art form designed to get the full, accurate story, all while building a solid foundation of trust.
And this interrogation isn't just random. It has three distinct phases. First, you've got orientation. You introduce yourself, you set the agenda. Simple. The middle part, the working phase, that's where the real work happens. You're gathering the whole story. And finally, you have the termination phase. This is where you summarize your findings to make sure you got it right, and then you professionally wrap up the conversation.
So what's the number one tool in your detective toolbox for this whole interview process? It's the open-ended question. These are questions that a patient just can't answer with a simple yes or no. They're specifically designed to swing the door wide open and invite the patient to tell you their story in their own words.
And this is a brilliant example of that in action. See, instead of asking something like, "Do you get tired during the day?" which is a closed question, you ask this. This question forces them to give you a narrative. It allows the patient to bring up details and connections you might never have even known to ask about. It's a total game changer.
Okay, so you've used your open-ended questions, and boom, the patient gives you a clue. Let's say it's stomach pain. Now what? A great detective doesn't just write down stomach pain and move on. No, you need a system to analyze that clue from every single angle. So let's really frame this up. A patient looks at you and says they have a symptom. What is your very first systematic move? You can't just start guessing. You have to have a framework.
And that framework is PQRST. Seriously, this mnemonic is going to be your best friend. It makes sure you never miss a single critical detail about a symptom. P is for provokes, what makes it better or worse. Q is for quality. Describe it. Is it sharp, dull, burning? R is for radiate. Where is it? Does it travel? S is for severity, the classic 0 to 10 scale. And T is for time. When did it start? How long does it last? This is how you turn a vague clue into a detailed forensic-level report.
Okay, this brings us to what might be the most critical thinking step in this entire investigation. This is the moment where you make that leap, from just collecting raw facts to actually solving the case and drawing a conclusion.
So what is the difference between a Q and an inference? You've got to know this. It's super high yield for the NCLEX. A Q is just a raw fact. It's what you see, hear, or measure. An inference, on the other hand, is your interpretation of what those facts mean. Qs are the evidence, the inference is your conclusion.
All right, let's build a case step by step. You walk into a room. Here's your first cue, your first piece of evidence you can actually see. The patient is lying totally still, arms flat at their sides. That's it. That's a fact.
But you don't stop there, right? A good detective keeps looking. So, here's your second cue. You look at their face. Their expression is tense, and you can see they're grimacing. Again, this is a directly observable fact. Now, you take those two separate cues, lying still and grimacing, and you make the logical leap. This right here is your inference. The patient is experiencing pain. And here's the crucial point. You cannot see pain. You can only see the cues that suggest it. Pain is always an inference, and it has to be based on the evidence you collect.
All right, let's wrap this all up with a final briefing. These are the high-yield takeaways, the things you absolutely have to remember as a clinical detective, especially when you're prepping for exams. So let's do a quick-fire recap of your detective's toolkit. 1. Assessment is all about recognizing cues. 2. Evidence is either subjective testimony or objective forensics. 3. Use open-ended questions to open them up, then PQRST to dig deep. 4. Know the difference between cues, which are facts, and inferences, which are your conclusions. And finally, the golden rule. Never, ever make an inference based on just one single clue. You gotta build your case.
And that brings us to our final thought. I'm just going to leave you with this one question to chew on. What's the single biggest danger, to your patient, to your license, to everything, of making an inference, of jumping to a conclusion with only one piece of evidence? Think about it.